All right. Hello, everyone. I'll get this started. I am Tom Lang. I'm on Abbvie's professional relations team. I have the distinct honor and privilege of introducing our promotional speaker here, Dr. Noralee Cothran, fresh off of optometry's meeting in Minneapolis, Minnesota. Dr. Cothran did her undergraduate at the University of Michigan. She went on to be an intelligence officer in the United States Air Force. Thank you for your service, Dr. Cothran, and think of Kelly McGinnis in the original Top Gun. Um, After her service, Dr. Cothran earned her Doctor of Optometry at the Southern College of Optometry, and then went on to do a residency in ocular surface disease at Bascom Palmer Eye Institute at the University of Miami School of Medicine in Miami, Florida. Dr. Cothran is currently practicing at the Eye Institute of West Florida, where she specializes in diagnosis and treatment of glaucoma and neurologic eye disease. She's a national speaker. She speaks for continuing medical education, and she is a fellow of the American Academy of Ophthalmology or Optometry. Um, Thank you very much, Dr. Cothran, and I'll turn it over to you right now.
Awesome. Thanks, Tom. Thanks, everyone, for joining the call. What a fantastic presentation. Will Yu has just done a great job of giving us all this fantastic CE that we can enjoy from our homes. And to wrap up the evening, I've got three cases that are focused on glaucoma. So tonight's presentation is entitled Moving from Reactive to Proactive Glaucoma Management. This is a non-CME program, so even though you did get CE for the previous presentation that you did watch, these next three cases won't be for CE, but hopefully you'll walk away from the presentation learning a little bit of something. All of the material has been approved by the FDA, and if there's any off-product questions, we're happy to get you in touch with Global Medical Affairs. So the question of the night: how are we treating differently than 20 years ago with glaucoma? And even in a different way, how are we treating differently than even 10 years ago? So I've been in clinical practice for about a decade now, and what I've seen happen in how we manage glaucoma is less about kind of hoping that the patient is doing the right things when we're not actively with them in the exam room, and they were kind of in the driver's seat, and now we kind of put them in the passenger seat, and the doctor is aware of everything that's in the toolbox, whether it's topical drops, MIGS, surgical intervention. Even as optometrists, even if we're not the ones doing these procedures, we need to know what's out there so that as we take care of the patient, we're able to plan out where along the journey of their glaucoma journey that the different tools in the toolbox need to be in play. This is just a timeline that shows this plethora of tools among the toolbox, and we've got SLT all along the patient's journey. We've got PGAs, combination medications, MIGS, and we've got sustained release and MIBS, which is minimally invasive bleb surgery, and then tubes and trabs. So topical drops are going to be there along the way of the entire journey, but instead of being drops, laser surgery, which was kind of the mentality, over about a decade or 2 decades ago, because there really weren't that many other options. We now get a chance to utilize our knowledge. And if you're a chef in the kitchen and you like to cook, I like to cook, and thinking about what ingredients are there, you can only make the best meal if you know what the ingredients are. So let's talk about a real world case. This is a 69-year-old Hispanic male. His IOPs were 26 millimeters of mercury in the right, 27 millimeters of mercury in the left. The patient is only 69. Things are really important because I practice in Florida. Patients are living longer these days, and they're also living better quality of life. And so we always take the patient's age into consideration. And we also want to know, what their family history was when it comes to glaucoma. We now know that patients have a family history of glaucoma can have up to a 9 times greater risk of having a little more aggressive form of the disease. We have a little more understanding of the genetics literature that's out there. And so this patient does have a family history of glaucoma from his father's side that he remembers watching his father lose vision. The patient was on generic latanoprost. And after 2 years on generic monotherapy, he's having pressure fluctuations. Every time he's in the office, sometimes the pressure's 19 can be upwards of 23 to 20, 24, and just fluctuations. The patients also talked a little bit about their ocular surface not feeling so well. And, he really says, I watched my dad take all these different drops as his disease progressed. I don't want to have the drop collection, is what he called it. And so 2 years after his diagnosis, his pressures are hanging in at 20 millimeters of mercury in the right and 21 in the left, but that's at 8:30 in the morning. So we need to remember that, patients' pressures are highest in the morning and they're slowly going to fall. So with this patient, I had them come back in the evening and recheck it, and the patient's pressures were still staying in the high teens, 18 to 19, even at 4:30 in the afternoon. And if the patient had stayed ocular hypertensive or did not have a lot of severe notable damage that was noticeable on our quantifiable testing, I wouldn't be so alarmed. But in just 2 years' time, you can see this inferior and superior thinning in the neural retinal rim in that right eye. And when you take a look at these optic nerves, you can see this thinner than average superior neural retinal rim. There's a little bit of a little malinsertion that's happening there with a little density at the superior rim, but some of that is very, very real neural retinal rim thinning. That thinning that we saw in the right eye that had progressed in 2024 in the RNFL corresponds to what we're seeing here on this 24-2, that inferior superior nasal step, that little lid artifact. So the target IOP that I would set for this patient, I definitely want to keep him 18 or below, or maybe even move him to the mid-teens. And, instead of, he didn't want to do a laser and he didn't want to do sustained release, and he definitely didn't want to add extra bottles. So we talked about switching him from the generic PGA that he was on. He was saying that every month when he got it from the pharmacy, it was a different manufacturer, a different bottle. Some were easier to squeeze, some weren't. And he's having a little bit of dexterity issues. The one thing that I like about what we changed him to in this particular patient, we changed him to Lumigan, and this is Bimatoprost 0.01. It comes in a 7.5 ml bottle. There aren't any PGAs out on the market of any teal caps that come in a 7.5 ml bottle. It's a 3-month supply for the patient, but my patients that are on this larger size bottle, they do find it's a lot easier to squeeze, a lot easier to be compliant. And the patient was at target. So sometimes when patients are, having pressures that are fluctuating, I think that it's important for us to listen to them. So if he felt like, that he was getting something, each time he said he felt like it was roulette every time he would go at the pharmacy, what he was getting and the size of the bottle, he said, if that medicine would just not come in such small bottles. So I took both those pieces of information and prescribed him Lumigan. Lumigan is indicated for the treatment of patients of open angle glaucoma and also ocular hypertension. This is a medication that has the standard PGA warnings of hypertrichosis, periorbital lid and lash darkening, eyelash changes. We know we need to be cautious in patients that have any active inflammation in the eye, on the eye. Don't put it in over contact lenses. And be careful about patients with a history of CME, and it's not indicated for use in pediatric patients. And that patient, for several visits after, maintained a steady IOP and was controlled to target. And so listening to our patients, something that we do very good as optometrists is to listen to what our patients are telling us. The second case study is a nice one. This is a patient that came into me on a prostaglandin and also a rho kinase inhibitor. The baseline pressures were in the mid 20s. The patient has had 2 SLTs back to back, and it did keep them off of medication. But as soon as the SLT wore off, the medication rose back up. This patient also has a father that had glaucoma who was also on multiple drops. The patient's best corrected vision is 20/20, but when I looked at the ocular surface and glaucoma therapies often go hand in hand, and that they're kind of besties. The two diseases kind of go. Sometimes the more medications we add on to the eye, we think we're helping the patient. We might be helping their glaucoma, but sometimes we're making their ocular disease a little bit more exacerbated, inflamed. And this patient had confluent SPK across the surface. They had a decreased tear breakup time, so they've got a aqueous deficient. They've also got probably a evaporative component to their dry eye, and their angle is wide open, and they have had fluctuating IOP, but they have this kind of hyperemia across the conj. And the patient said that they felt like their eyes eyes were getting more and more aggravated as their glaucoma, as they lived with glaucoma. And so this patient, overall, their visual field is intact 100%. They do have that classic superior and inferior thinning in the right more than the left. It's classic glaucoma type damage. And some docs would look at this patient and say, you know what, this patient's fine. Patient's pressure is controlled to target. The patient's VFI, they don't have any visual field defects, not 1 degree of a nasal step, and their RNFL appears to be staying stable. And even though that may be the case, we know that other different types of diagnostics like this GCC analysis can give us a little bit more of a prediction into the future. So from 1 year to the next, we see a little bit of progression, this classic inferior wiper defect, and it looks like a windshield wiper, inferior temporally on either the right or the left side, respectively. But in both cases, it was increasing in time and worsening. And there was also a little bit of a vitreomacular adhesion that you can see there that was similar in both. And so we do have a little apples to apples comparison there. But the patient was really, really uncomfortable with, the surface of the eye, and they felt like they were having fluctuating vision. So remember, the patient's vision was 20/20, but the patient subjectively felt like it was fluctuating, probably because of the unstable ocular surface. So I talked to the patient. I said, hey, there's a tiny little pellet of the TL cap that we could put into the eye. It's usually covered by insurance, and the medicine goes in the eye and works. And there's Argos data out there that shows that at 18 months, 77% of patients still had pressure control with the intracameral bimatoprost. So the first case we talked about doing topical bimatoprost. The next we did intracameral bimatoprost. So Durysta was administered as an alternative to drops. The patient's pressure was right at target with the bimatoprost. And what was nice is that the patient was we were able to down titrate off of the drops. But remember, the patient was on 2 types of mechanisms of actions of drops before, but they got about equally efficacious effect through this one intracameral bimatoprost. And it had to do with the patient's compliance. The patient later said, some nights I just chose one or the other and put them in. And so the more that you start to talk to the patients and listen to them, the more that you're going to be able to help them. So Durysta is just an intracameral form of bimatoprost, also indicated for patients with open angle glaucoma and ocular hypertension. The same warnings and precautions profile because it is a prostaglandin. When you, as an optometrist, are seeing these Durysta patients, make sure you put the gonioscopy lens in, take a peek in that superior mirror to look down in the inferior angle. You'll see this tiny little pellet hanging in there in the angle, and you can monitor it as it slowly dissolves in time. The last study of the night is a real-world case study, and this is a patient that's truly on the drop collection, max tolerated medical therapy. And they actually have already had cataract surgery where they had a hydrous microstent placed. They'd also previously had an SLT before they had the CE hydrous. And the patient was still back on drop. So they had really good pressure lowering for about a year. And then the pressure started rising. So the doc, prior to me managing them, had started adding drops back on one at a time and then adding another one. And the patient was getting very confused about which one was twice a day, which one was once a day. The patient was getting really kind of stressed about it. So some days they just wouldn't do any of the drops. And so the patient's on 3 bottles of medicine, in the entire drop collection. The 5th mechanism of action, the rokinase, they could not tolerate that medication, so they weren't on that one. But when I saw the patient, they were 26 and 29 millimeters of mercury. This is a patient that has a larger than average CD within a smaller than average disc. And when we take a look at the testing here, we actually see that even though overall, if you were to just kind of take a look at the analysis of the field in the top right, it looks fairly open, but when I look at the pattern deviation of this patient's left eye and the right eye, I look and see a growing field defect that is getting dangerously close to the central 10-2. And so for a patient that is already on all of these drops, they started off on all of those drops, they had cataract surgery, they had the hydrous, pressure stayed great for about a year, and then it started slowly creeping back up. This patient has a more of an aggressive form of the disease that I want to stay on top of. So right now, for this particular patient, I went ahead and put them on oral Diamox to get the pressure down, and then I sent them to my glaucoma surgeon for a MIBS, for minimally invasive bleb surgery. So what this is a procedure called the Zen. This is a tiny gel microstent. It's about 10 millimeters long, and it's placed into the anterior chamber, either ab on label, ab internal. And you'll find this perfectly compact, perfect trab kind of over the area. It's usually going to be superior temporal. When you look at these patients, you'll want to lift that lid. The Zen gel stent is about the size of Barbie doll is drinking a boba tea. It's about how big the straw would be in the boba tea. It's tiny. And so it's very different than the tube that you might see if you were to look at a Barrel or an Ahmed valve. Now, this patient had a Zen implanted, and what was really nice is that on post-op day 1, patient's pressure was 10, and they were on no glaucoma drops. They were just only on the difluprednate and the moxie, so the steroid and the antibiotic. And then over time, we tapered off of the steroid in a very controlled manner. And from the 6-month mark, all the way up until month 47 in this particular very real world case, the patient's pressure stayed controlled between 12 to 14 in a nice, safe place without any medication. And you've still got one of your SLTs still in the toolbox. And so the patient, they really enjoyed being drop free after their cataract surgery. They had the cataract surgery, the hydrus. They enjoyed that time period of not being on drops, and you could see the defeat in their eyes when the pressure started rising back up. I almost felt like they were like having PTSD from the first go around, because when they were having all these drops added back on, because they felt like they were kind of fighting a losing battle. And I explained to them, I said, look, we're on a journey together. And at this point in the journey, we need to call in the big guns. We called in my cataract surgeon, did the cataract surgery and the stent. Now we got to call in the big guns with my fellowship trained glaucoma surgeon to do the stent. And I'll be with you the whole journey. And so this is a procedure that's indicated for not only primary open angle glaucoma, but also pseudoexfoliative glaucoma, and also pigmentary glaucoma, because the clinical trial had enough patients in it to make sure that this procedure was safe. And so even though optometrists aren't doing this, obviously not doing this procedure, I think it's important for you to know what it is, know what it looks like, and to know that it can make a real big difference in patients' quality of life. The patient is nice and stable, complete stability over time in years, over the course of years. And remember, pre-Zen, they were ranging from 26 to 29 on max medical therapy. And if you look in the image there, you can see that tiny little, almost like semi-translucent stent there, right there. And it would be right at that 11:30 position in this picture. And post-Zen, this patient's pressure is nice and controlled between 10 to 12 to 13 millimeters of mercury. And so what should we be doing differently in 2025? I think we need to get out of our mindset that, it's drops, laser surgery. I think that we as optometrists need to feel empowered to take extra steps, whether that's switching medicine, whether that's taking the initiative to talk about the possibility, hey, Mrs. Jones, you're having a little trouble maybe getting this drop in. That drop comes in a pellet. How about I set you up with one of my MD colleagues to meet with, to talk about this, or to say, hey, Mrs. Jones, we are at a place in our glaucoma journey where we have stopped off on all of the pit stops, and now we need to take a detour. We need to get off the exit, off the highway. We need to gas up the car. Or my grandpa, he's a NASCAR fan, so I say we need to stop at the pit crew and change off, switch out the tires, get everything ready, get back on the track. And to let these patients know that we're there for them. We're there to care for our community. And as optometrists, it's something that we do very well. So listen to our patients, set your treatment goals, and talk to them about the sequence of what to expect. So I really appreciate you guys joining for WooU for the CE. Thanks for hanging in there for 3 more cases to talk a little bit about glaucoma, and I'm happy to address any questions that you might have.
Dr. Cawthorn, we did actually have a question in the Q&A. It is, if a patient receives a Durista implant, how do you manage the other glaucoma medicines?
That's a really good question. Remember, the Durista intracameral is bimatoprost, so it is the PGA molecule. So actually, when I tell my patients that they're going to have a Durista, I tell them, look, the little teal cap drop that you take, you can stop that one the day that you have the pellet done. And they say, well, I don't have to take it that night. No, ma'am, you don't, or no, sir, you don't have to take it that night, because once we put it in the eye, it instantly starts working. And it's really nice, because if a patient responds to a PGA, we know they'll respond to the Durista. So I actually have the patient stop the PGA that night. And then when I see them back for eye pressure check, if their pressure is even lower than what it was on the PGA, then I know there might be a compliance issue going on. So then I slowly start down titrating some of the other drops. And about half the time, I'm usually able to get them off of yet another bottle of medicine, not because the bimetoprost is working any differently, but it's because of a compliance issue. So I have them stop the PGA that night. Excellent question.
Looks like one more question. What is your opinion on ERG in 2025 for early detection of glaucoma? Functional change preceding structural or field loss?
That is also a good question, and one that I get asked often as a member of the AOA's Coding and Reimbursement Committee. There is a reason why CMS and commercial insurance companies don't reimburse for ERG if you use glaucoma codes. So some companies will tell you, oh, you use an optic atrophy code or use a different type of a code. Just because you can do something doesn't necessarily mean that you should do it. And so I say that very cautiously because as optometrists, we are utilizing that particular device in a much larger and greater quantity, using codes that are similar to glaucoma, but that aren't glaucoma. And I actually did an informal poll at the American Glaucoma Society because one of my optometry colleagues did not believe me. And I actually stopped asking MDs because they were literally laughing at me. And they're like, what, using ERG for glaucoma detection? And none of them were. Not a single fellowship trained glaucoma surgeon that I talked to was utilizing that in the office. And what I think of is that would the utilization of it change how you're going to treat the patient? And if the answer is no, then do you really need to be utilizing that technology? And so for me, as somebody that lives and breathes the glaucoma space all day, every day, I recognize that it is a great tool for diabetic retinopathy, for other types of retinal diseases. But for me, taking a look at something like the GCA does give you good information. And we have very good fidelity when it comes to taking a look at patient central 10-2s and actually just using your own eyes and looking at the optic nerve and being able to see what areas of the optic nerve look vulnerable. So I just would caution every optometrist on this call to be very cautious about your use of, if there's a reason that a few years ago, CMS stopped reimbursing for VEP and ERG for any of the H40 codes that are related to glaucoma.
Okay, we're getting a couple questions in just related to that one. What code do you use if not diagnosed yet as glaucoma, but doing procedures to determine if glaucoma or not?
Yeah, that's a good question. So a code that I do use is a glaucoma suspect or ocular hypertension. And so if there's anything suspicious about that patient, the appearance of the optic nerve, or some patients have, they may be a high suspect because they say mom and dad both had glaucoma. So you can use a suspect. So borderline, it will be in the ICD-10 list as borderline glaucoma, high or low risk. And so that would be a suspect. And if you look in the eye and you actually see that you're pretty sure there is glaucoma, before you quantify it, if you're going to bring them back for a field, you can put glaucoma. You don't have to quantify it as mild, moderate, or severe. You can put indeterminate type. But you can always use the glaucoma suspect codes, or the borderline glaucoma, or ocular hypertension is always one that you can use if the eye pressure is starting off a little bit above average, but you want to bring them back for some more testing to kind of see where they fall. And then you can always change codes. You can always change the code, so you're not locked into one thing. You may have something listed as a patient has ocular hypertension, and then things look great, and then all of a sudden you do a GCA and you realize that they've got these big wiper defects, and then you can start, you can always fine tune things as long as you're justifying it in your INP. That is a really good question.
And then related to that, H40.013 is correct, if you know that.
Right off the top of my head, I am on the East Coast and it has been a very long day. So, but it sounds right, but I don't have the IC as I do have H40.1133 because that's my license plate number. But there is a code. If that doc that's on the call can always reach out to me, and if they're AOA members, they can always reach out to ask the coding experts. And that is ask the coding experts at AOA, and then somebody will immediately get back to you just to confirm that with you. But or they can reach out to me, they can text me, call me, or email me, and I'm happy to double check that one. But right off the top of my head, I don't have that one memorized.
Okay, this is a active chat screen here, Dr. Cothran. So if
Okay, cool.
SLT is done first, but effects fade, are topical drops less effective than if used without SLT?
Excellent question. And the answer is no, because they utilize different mechanisms of action. And so, and it also is some patients will ask me, they're like, well, if we do, because I always tell patients, I said, we can either do drops, we could do a drop, the pellet, we can either do drops on the eye or drops in the eye, which would be the pellet or the laser. And I always put those options out there. And some patients say to them, you're going to need a combination of these. And they always ask, well, does the order matter? And will it affect the other? And I do get that from patients, and the answer is no, because the mechanism of action of our medications, they are the two different things, are not mutually exclusive, and one does not temper the effect of the other. Now, I will tell you that if we are using aqueous suppressants, we know that long term that can impact the outflow through the trabecular meshwork, and we may have a little bit more of a brittle, a little more frail TM. And so that could impact how different therapies that do target the TM work in the long run. But that's after someone's been on those drugs for years and years and years. But that's a really good question.
Okay, one more. Why normal tension glaucoma prefers central field defect rather than peripheral?
Excellent. And I'm so glad that this was brought up, because I've always known it as someone that lives in the glaucoma space, that these normotensive defects show up paracentrally or centrally. That's why it's so important as ODs that we're doing 10-2s. So we talk about 24-2s, 24-2s, always get a baseline 10-2 on your patients, and you can bill for it. Just do it at a different visit as the 24-2, because especially if a patient is right at the upper limit of normal, you may see a central field defect that shows up on the 10-2, even when the patient's 24-2 looks perfectly normal. We don't know exactly why, but we do know it's present. At the American Glaucoma Society, this past meeting, we looked at an analysis of some of the genetics data that's out there, and it did show that that patients that have the genetics that are associated with normal tension glaucoma also happen to have paracentral and central scotomas. So we don't know why it's happening. We do know that it is definitely not like it is more than just a casual observance. It's clinically linked when we look at the genetics. And so as optoms, we should definitely be screening for it and being on the lookout for it. If you have somebody that doesn't refract or best correct to 20/20, there should always be a reason why. And a central scotoma that's hidden under the 24-2 should definitely be high on your differentials if the patient is NTG.
Okay, I'm gonna thank the anonymous attendee that said this was an autocorrect, so I can just correct it on my own. Our iris, not Irish, pigment changes significant with Durista compared to GTTS?
Yeah, that's a great question. So the effect on the label indications that have kind of those adverse events for pigmentary changes are going to be the same for the intracameral bimatoprost and even the topical prostaglandins, because they both are prostaglandins. There were no more increase or decrease, concentrations of those changes between whether the drop was on the eye or the medication was in the eye. But what I will tell you clinically is I've only seen iris pigment changes in 2 patients in 10 years of clinical practice. And they were both in hazel eyes, and they were both only noticed by me under the microscope. And one of the patients, I mentioned it, the patient opted to discontinue the prostaglandin analog. The other patient, I mentioned it, and the patient said, I don't care, I'm at a safe place, it doesn't matter to me. And so patients are usually, that's the one thing they're very afraid of. I always tell them, you are much more likely to get longer, thicker, darker eyelashes than you are to be one of the very few percentage of patients that might have an iris change. But rest assured, if there were to be a change, I would be able to notice it in the microscope before you would see it. So it's there is when we look on label for the FDA, both are labeled equally as both having that side effect.
Okay, I'm going to read this just as it comes across, but do you recommend baseline 24-2C to include some central testing when you say baseline 24-2 and 10-2? Would I be able to combine and do 24-2C?
So that is a good question. So I just personally am not a fan of the C. I know why it's there. I know why it was created. I like an actual proper 10-2 to get more of those points. The 24-2 with the C is adding just a few more extra points in that central 10-2, but it's not actually giving you the exact data down to the degrees that you would actually be able to see in a proper 10-2. So instead of trying to get as much information out of one field as possible, I like doing a standard 24-2 and then bring the patient back on a different visit. And you could do the GCA and do a 10-2 on that day. And you can bill for two separate fields on two separate days. And the patient, I think, would benefit from that, because if you do find a field defect on that 10-2, then you follow them forward with that 10-2. The fidelity of the 24-2C, it's acceptable, but it's looking for gross defects in that central field. These very subtle 1 to 2 degree changes that you might see, these scotomas, can be washed out on that 24-UC.
Okay, it looks like that's it, Dr. Cawthorn. I just want to thank you
Woo!
on
Oh
behalf of
my gosh, you guys
Abbvie.
make me sweat.
Yeah, that was a lot of questions, and I just want to thank the attendees for the engagement and for everybody hanging on. But thank you very much again, Dr. Nora Lee Cawthorn, and I think that concludes tonight.
Thanks, Tom. Have a great night, everyone. Bye bye.